Welcome back to the Ninja Nerd Podcast. Today we've got a great episode on amyloidosis. Zach, you pumped up, man? You ready?
I think this is a cool one. I like this one.
Let me ask him that again. Are you pumped up? Are you ready?
Fucking yeah!
That's better. That's better. Let's get into it. Here we go. We have a case here, Zach, and we're going to go over our usual types of structure here, okay?
All right.
67-year-old male presents with progressive fatigue, lower extremity edema, and new onset of orthostatic dizziness. Patient freaking stands up and boom, they hit the floor. HPI, the patient reports worsening fatigue over the past 6 months. He also has noticed swelling in both legs, particularly in the evening times, and unintentional weight loss of 10 pounds over the past 3 months. Additionally, he experiences dizziness upon standing and occasional palpitations. He denies chest pain, shortness of breath, fever, night sweats, or recent infections. He mentions intermittent numbness and tingling in his fingers and hands bilaterally over the past year, which he initially attributed to aging. Sure, we all get that, right?
I guess, yeah.
He also states that
I can't feel my fingertips. I'm pretty sure it's normal.
This next one's weird. This one would be, I'd be concerned about this one.
All right, hit me.
He also states that his tongue feels larger than usual, making it difficult to articulate words at times.
Yeah, I'd say that's kind of abnormal. Yeah.
That's bad. That's so bad. We can't attribute that one to aging, right?
No, I don't think so.
No, I don't think so. His past medical history is pertinent for hypertension, type 2 diabetes, hyperlipidemia, and no known history of malignancy. He's on some medications like metformin, lisinopril, and atorvastatin. For our review of systems, general, he's feeling more fatigued. He has weight loss. Cardiovascular, he does have occasional palpitations and orthostatic dizziness. His neuroexam, we have bilateral hand numbness and tingling. Gastrointestinal, mild dysphagia, occasional diarrhea. And for his derm, we noticed easy bruising around his eyes. All right. Well, let's go into his physical exam and find out some more information. For his vitals, we have BP 110/70. Now, we did note in his history that he has the orthostatic dizziness upon standing.
I'm assuming they did some orthostatic vitals.
Exactly. So we do some orthostatic vitals upon standing. And initially, again, BP was 110/70, but upon standing, it drops to 85/60. Heart rate is 88. Temp is 36.7 Celsius. O2 sat 98% on room air. For his skin, we noticed periorbital purpura, or it's another term for that is raccoon eyes.
Yeah.
Cardiovascular, we have irregular rhythm.
Which should be funny. I feel like sometimes I look like that, you know?
Yeah. Waking up in the morning.
I'm like, oh man, I must not have got any sleep.
Yep. We'll attribute that to aging, right?
Yeah, let's just say that's aging too. I don't know. I probably had that when I was like 6 years old too, though, but who knows?
Once again, cardiovascular, irregular rhythm. I couldn't say that 5 times fast.
Yeah.
That's a tongue twister. Elevated JVP. Pulmonary, no rales or wheezing. Abdomen, mild hepatomegaly, no splenomegaly. Neurologic, we have decreased vibratory sensation in bilateral feet. Musculoskeletal, we noted that mild macroglossia noted of the tongue. Extremities, we also have a 2+ pitting edema in both lower extremities.
Lot going on, a lot of systems that are just, something is happening where this disease is wreaking havoc on them.
Seriously, I mean, this is like absolute systemic involvement to the max.
Yeah.
All right, so let's break this down, Zach, step by step like we normally do.
Okay.
You have a 67-year-old male, progressive fatigue, lower extremity edema, orthostatic hypotension, some unusual symptoms like macroglossia. That's a big one. And then we have the raccoon eyes or the periorbital purpura.
Yeah.
What in the Sam heck is going on? Please tell me and tell everyone else out there watching.
All right. So we know based upon this podcast, if you're tuning in, it's about amyloidosis, right? But the funny thing is that when we talk about amyloidosis, there is many different types. And so there's AL amyloidosis, there's AA amyloidosis, there's ATTR amyloidosis, and there's A beta 2 microglobulin amyloidosis. And so you have to try and kind of come to the conclusion of which one it is. Most often it's AL amyloidosis, and all that A stands for is amyloid, which is an abnormal protein that's usually a beta pleated sheet. If you go back to your basic biology, and it's harder to break those down. They build up in tissues. They cause destruction of the tissue. And the L is for the light chains. So there's plasma cell disorders. So we've talked about this not too long ago.
Yep.
Things like MGUS, monoclonal gammopathy of undetermined significance, multiple myeloma. Those are disorders where your plasma cells are malignantly producing lots of immunoglobulins, and particularly the light chain is the problem. And these light chains, they build up, they start misfolding, they become amyloid-like, and then they deposit into tissues. The most common tissues is the heart, so they can get restrictive cardiomyopathy. And funny enough, with restrictive cardiomyopathy, it can present like heart failure. And it's usually right-sided. And when I look at this patient, they had some JVD, so the jugular venous pressure was elevated. And then it also will cause lower extremity edema. So they have some pitting edema in both their lowers.
Yeah, sure do.
The other thing it can hit is the kidneys. So they can end up with nephrotic syndrome. Nephrotic syndrome is not always easy to diagnose. It can cause edema, but it also will cause abnormalities in your protein in the urine. So if we ever to check into this patient, we probably see that they would have very, very high protein in their urine. They probably, even to a degree, have low albumin in their blood. And so that's something I would actually try to investigate, and I would assess for. The other thing that's really important for these patients is neuropathy. So AL amyloidosis, those proteins like to deposit on the nerves in the periphery. Autonomic is a big one. And that's where the orthostasis could probably be coming into play, because it gets into those neurons there, deposits around them, and you lose the sympathetic supply to your vessels. They can't constrict when you stand up. Your pressure isn't good because you don't have good venous return to the heart, and that's where you get that dizziness and your blood pressure drop. It can cause erectile dysfunction, so the pecker won't work, and that's a problem, obviously. But the other thing is it can cause gastroparesis, and sometimes that can come with like nausea, vomiting, weight loss, and things like that. And so this person did have an unintentional weight loss of 10 pounds. That could be contributing to it. And that also can contribute a little bit to like some dysphagia too. I'd say the other thing here is I do worry about macroglossia. That's whenever you get lots of deposition of the amyloid into the tongue. And so that's another potential presentation I'd be watching out for from the GI involvement. So you've covered cardiac, you covered renal, you covered neural. GI likes to attack the tongue. It also can attack the liver and the spleen. And did they have hepatomegaly?
It was mild.
It's a mild hepatomegaly. And then the other thing is it does attack the intestinal villi, and then it impairs absorption because those are supposed to increase your surface area. So they'd probably have some degree of diarrhea, and probably even that would contribute to weight loss as well. So they had weight loss. They also have diarrhea that they endorse too.
Yeah, just like we talked about. I mean, they're hitting a lot of systems.
It's like
here.
a classic kind of AL type picture in this thing. And then skin is another really big one. And the most common one is like easy bruising, but it usually occurs around the eyes, raccoon eyes, which is kind of a characteristic sign. And then you can see some musculoskeletal involvement too. Usually it likes to hit the shoulder joints. And I'm not even kidding. These dudes walk around like they look like they have shoulder pads on. It's called the shoulder pad sign.
I couldn't believe it when I saw the picture of that.
It's insane.
We'll pop it up right now. It really is crazy because it's the only thing that's really enlarged.
Yeah, they really honestly look really sick, and then you just see their shoulders with this massive deposition in there. So that's the things that would be concerning for me, but there's a lot of things that I would have to start really evaluating. There's probably some good labs I'd send off to see if I can find some of this multi-system involvement and maybe even some imaging too.
Okay. Well, I have some questions here because I'm curious about really the kind of the cascade you would go down for ordering labs.
Okay.
If you can tell me kind of like the overall testing for each one you would like to hit here.
I mean, whenever you have a patient like this coming in, it's always good. Whenever you have a patient with like fatigue, anytime you hear fatigue, always just get a CBC. It's always good to find anemia. Anemia is pretty common in amyloidosis because it's a part of, so multiple myeloma is probably one of the most common triggers of AL amyloidosis. And so do you remember the mnemonic for the crab mnemonic for multiple myeloma?
I do, yes.
And so the A is for anemia. And so that's one thing I'd probably look for. That's a pretty common one. That could explain some degree of the fatigue.
Okay.
I'd get a BMP, but I would actually probably escalate it to a CMP, so which is my renal function and my liver enzymes, and I'd look to see if I can find any evidence of nephrotic syndrome. Like sometimes there can be some kidney injury in there, so I may see a bump in the creatinine, but I'd look for any evidence of kidney injury. I'd look for any kind of like maybe meddling increased LFTs from the hepatomegaly that they have because it can infiltrate the liver. It's usually more cholestatic in nature, but I'd probably look at that. I would consider like a BNP and troponin to look to see if there's any kind of significant heart involvement. I would combine that with an EKG though and an echo to really see if I have any concerning features of like restrictive cardiomyopathy. And the biggest thing I would do is I'd probably get a urine protein creatinine ratio to really look to see is that, because the two biggest ways that amyloidosis will present is restrictive cardiomyopathy and nephrotic syndrome. And so the two most important out of all of these is I would say get your EKG, your echo, maybe a troponin. That would take care of the restrictive, at least getting it started. And then we'd follow up with more tests. And then the other part is get a urine protein creatinine ratio. Because if I get the EKG, it may show conduction blocks. If I get the echo, it'll show me this super like thickened ventricles and biatrial enlargement. And then if I get the urine protein creatinine ratio, that ratio should be pretty high to where I would see they're making more than 3 grams of protein in their urine in a 24-hour period. So that's kind of how I would get started to see what it would give me.
So we get some results back then. Okay. We try and hit all those areas you talked about, and we get the following. Hemoglobin, 11.2. Creatinine of 1.5 with a baseline of 1.0. Albumin is 2.6. BNP is 950. Troponin's mildly elevated, and our urine protein we get back is 4.2 grams over a 24-hour period. Does this confirm your suspicion for AL or amyloidosis?
I would say right away, I'm definitely concerned with the nephrotic syndrome picture. That's what really concerns me. I would follow up the troponin with an EKG, and if the EKG showed some maybe, you know what the characteristic sign is for your exams? Know this, it's always a low voltage QRS complex. It's a pseudo infarct pattern that we see in restrictive cardiomyopathy, but I get an echo after that just to make sure I don't see anything. But I 100% see nephrotic range proteinuria. And whenever you see nephrotic syndrome, you should always think, okay, what are my thoughts? It's either primary or secondary. So primary is either your minimal change, your membranous nephropathy, focal segmental. Those are harder to determine. The secondary ones are your diabetes and your amyloidosis. And this patient has that picture of the amyloidosis from all this systemic infiltrative involvement. So that's what really concerns me. Cardiac dysfunction, there's a troponin elevation. I would definitely follow up with an EKG and echo, really follow that up, and maybe even a cardiac MRI to really see if I have any evidence of restrictive cardiomyopathy. But yeah, for sure, I think that this is definitely leaning more towards AL, amyloidosis, as compared to anything else.
You have those different types of amyloidosis. So how do you definitively confirm that diagnosis depending on which one it is?
Yeah, so we actually should do a tissue biopsy. So to find this amyloid protein, I'd actually want to take a tissue biopsy. In a perfect scenario, you take it from the organ that's affected. So a renal biopsy would probably be the best thing if they have nephrotic range proteinuria. But you can actually get away with a less invasive one, and it's actually more preferred, and that is a abdominal fat pad biopsy. And so you'll take that, and it has a pretty good, I'd say somewhere around like 85% like sensitivity, so it's not too bad. Obviously, if that was negative and you still had a high degree of suspicion, that's when I would go for the organ-specific biopsy. But a tissue biopsy, I do abdominal fat pad, and then what I would do is if I think that it is amyloid, you take a Congo red stain, put it over that, and I'm not even kidding, this thing looks like the Aurora Borealis on the slide. It's called apple green bifurengence. So once you put that Congo red on there, it should really light up nice and green. And that's basically highlighting those amyloid deposits in that tissue. So that's kind of how I would go about it.
Well, it just so happens that we do get an abdominal fat pad biopsy.
Okay.
And for those watching, just so you know, it returns back positive for amyloid deposits with Congo red staining, showing apple green birefringence under polarized light. So what next?
All right, so we got amyloidosis.
Yeah.
And I suspect that it's AL, but you can't ever do that completely just based upon presentation. I would say that from here, we'll do the mass spectroscopy of that sample. And so what that means is I would take that tissue biopsy and I would throw this through like a mass spec, and that may help to separate out. It's kind of like the Maury show, like who's the father kind of thing. Like it'll tell you, oh, it's not AA, it's AL. You are the father. You know? So that's kind of the best thing about this one is the mass spec, except we don't test that clinically.
Okay.
I'm sorry, we don't test that in the exams. It's more of a clinical concept. So you would actually truly send off that for mass spec, and it would basically tell you, oh, based upon the spike on the mass spec, that molecular weight matches with the serum amyloid A. So therefore it's AA amyloidosis. Oh, this molecular weight matches with transthyretin. Oh, it's ATTR amyloidosis. This one matches with the light chains, the kappa lambda. That's AL amyloidosis. This one matches with the weight of the beta 2 microglobulin. That's amyloid beta 2 microglobulin amyloidosis.
Makes sense. Yep.
That's the way we would do it in clinical reality. But in true vignettes, they like to do it a little bit different in the sense that we use the history to really provide us this. And so what you'd actually probably do is you'd probably say, okay, I get the mass spec truly. But if I think it's AL, I would do what's called an SPEP. And we go back to all that stuff.
Yep.
You know, the Shaka. So you do the SPEP, the UPEP, and the free light chain ratio. And all you're looking for is that M spike on the SPEP and the UPEP. And if you see that, oh, okay, there's lots of these monoclonal proteins in there. I would check the light chains because I need the light chains to be really, really elevated because they are what's causing the problem. They're the problem. And so if I got my SPEP, my UPEP, I do an immunofixation to see if it's IgG or IgA, and then I do my free light chain ratio, that would be the way to go about this. And then I would also take into consideration history. So AL is always plasma cell. AA, look for like a history of rheumatoid arthritis, SLE, inflammatory bowel disease, a familial history of fevers and serosal inflammation, which suggests what's called familial Mediterranean fever.
Oh, wow.
That would suggest the AA. ATTR, that only really affects the heart. So I wouldn't see many other tissues, so I can kind of already put that one off the table to a degree because I see renal involvement and other tissue involvement. ATTR, usually you see this in old people if it's senile, or you see it in the family history. So familial, what's called ATTR mutations. And then the last one is alpha amyloid beta 2 microglobulin. I would look for a patient with end-stage renal disease who's been on hemodialysis for a long time, and they have been able to clear that beta 2 microglobulin. So in this one, I don't see that end-stage renal disease, hemodialysis for more than 10 years. So it's unlikely that one. I don't see any history of RA, SLE, inflammatory bowel disease, and I don't see any history of like frequent fevers and serosal inflammation. So AA amyloidosis is probably out. And then ATTR, again, I would see this in an older individual with just, how old is this person?
They were 67.
So they're on their older range. We like to see them usually greater than 70 for the
maybe close.
Close. So you can have senile ATTR. That's usually greater than 70, and they only have cardiac involvement. And then you have hereditary or familial TTR, and that one we would usually see cardiac and nerve involvement. And so there is some of that, but could it be possible? It could. The mass spec would be the thing that would tell me that in true reality. But if I get that positive SPEP, UPEP, and free light chain ratio, I'm pretty much going to go with its AL.
Well, let's give you and everyone else some answers here.
All right.
We have an SPEP, UPEP coming back with elevated monoclonal protein. FLC ratio is abnormal with elevated lambda light chains. And then for our mass spec, it does confirm AL amyloidosis.
Boom. So that would be the way of kind of going about that for sure, Ski. So if you got that monoclonal, the M spike, tells you that you got a lot of these immunoglobulins in the blood. The light chains are super, super elevated. It tells me you got lots of light chains, and those things are just misfolding and depositing into these tissues. And the mass spec is really the key thing because it'll show you which protein is elevated. Is it transthyretin, ATTR? Is it amyloid A, AA? Is it increased light chains, AL? Or is it the beta 2 microglobulin?
How do you continue to further evaluate the extent of systemic involvement?
So this is where I would say, okay, if a patient came into me and I saw nephrotic syndrome, or I saw some kind of like meddling features of like restrictive cardiomyopathy, or they got diagnosed with amyloidosis, right? Let's say that they just started off. Let's pretend that nephrotic syndrome was the way that they presented. Got diagnosed, got a biopsy, we found amyloidosis. I would want to see there any other systems that are involved that I actually don't see clinically. And so one of the things I would do is I would right away look for a cardiomyopathy or any kind of infiltrative pattern. So I would start off with an echo and an EKG. The EKG would give me that like pseudo-infarct pattern, any kind of conduction blocks, but it's not going to be the greatest. The echo will show me biventricular kind of like thickening and then a biatrial enlargement. And if I see that, I would then go get a cardiac MRI and look for what's called late gadolinium enhancement. All this tells you, and don't go too crazy, whenever there's fibrosis, inflammation, scarring, deposits, all those things, contrast is supposed to run through the myocardium and then drain out of it. So that's how we kind of, and it shows up very, very bright on MRI. if you have anything that's trapping that gadolinium, like inflammation, fibrosis, or deposits, that gadolinium can't get out of the myocardium, and it stays really, really bright. And so that's one way that we would see that. And it actually looks, I'm not even kidding, like they kind of explain it as like a donut dusting. Like, you know how you have like sprinkles all over a donut or whatever?
Sure do.
That that's kind of the way we would describe it, as like a speckled pattern. And so that's pretty much like pathognomonic to a degree for amyloidosis. So that's what I would do there. The other thing is I would do is if they have neuropathy, they have some degree of neuropathy, I'd probably get an EMG, nerve conduction study, to see if there is truly a neuropathy there. And then again, I would keep an eye on that urine protein creatinine ratio and keep an eye on renal function to see, is the nephrotic syndrome present? Is it getting any better with therapy, etc. I'd say those would be the biggest things to look for.
You've really harped on the cardiac involvement here, and to a certain extent, good. That we need to make sure we're thorough there.
Yeah.
So we talked cardiac MRI and echo, and then the EKG.
Yeah.
So let's go ahead and say we did order those testings, and let's see what we get back here. So we have our cardiac MRI showing diffuse myocardial infiltration with subendocardial late gadolinium enhancement.
There it is, yep.
Which is what you've talked about. For echo, reveals a thickened ventricular wall with a speckled pattern.
Gotcha.
And of course, like you said, the ECG shows that really common finding of low voltage.
Yeah.
So I want to know now, Zach, what is the best approach to treating AL amyloidosis? We got to this point. How do we treat this patient?
This is the one where you treat it like multiple myeloma. So if it was AA, you actually treat the underlying diseases. If it's ATTR, like that one, you actually, if it's like hereditary, you have to give them a liver transplant. If it's not, and it's like an older person, you can give them like a drug that's called tafamidis. And then if it's beta-2 microglobulin, you just change the type of dialysis. But this one, it's actually like, it's a malignancy. So you actually have to treat these patients with chemotherapy.
So you're almost thinking AL, you're thinking like multiple myeloma.
Yeah. And so like I would, if I really wanted to confirm that this patient has multiple myeloma, we got the SPEP, the UPEP. They probably have an SPEP that's greater than 3 for that M spike. They probably have the UPEP that's showing lots of Bench-Jones proteins, free light chain ratios through the roof. I would then go technically and do a bone marrow biopsy to look for the plasma cells that are greater than 10%. And that would tell me it's multiple myeloma. And so from that, I'm going to treat this like it's multiple myeloma. And so it's the VRD regimen. You hit them with bortezomib, which is for some reason the abbreviation, the 1-letter abbreviation is V. So V bortezomib. R is lenalidomide, and then the D, finally, actually one makes sense. It's dexamethasone.
All right, we got one.
Yeah, so I would do that, the systemic kind of like chemotherapy there, and then from there I would actually kind of look to see, are they a hematopoietic stem cell transplant eligible. If they are, I hit them with high-dose melphalan prior to that and then do the transplant. But if they can't get a transplant, you just do that chemo, and that's really it.
And you would consider that more so to transplant in a younger patient?
Yeah, I'd say they have to be kind of have a degree of medical fitness in the sense that they're somewhat on the healthier age but young, and they would be able to truly benefit from that kind of like transplant. If you're already getting towards the older ages in your life, it's starting to beg the question if it's kind of like worth it.
How about supportive care?
Supportive care in this patient, I would say they do have some edema, probably from the nephrotic syndrome.
Yep.
Diuretics are usually the way to go there. And then again, treating the underlying issue will really help this patient. They probably have some restrictive cardiomyopathy. And so from that, it's really, you just treat them symptomatically. And so you're going to treat them just like you would any kind of heart failure patient with guideline-directed medical therapy. If you need to, you can always consider beta blockers, but oftentimes the best thing is diuretics. You're just trying to prevent some of the excess fluid that's actually accumulating in the tissues.
What type of diuretic, just out of curiosity? What do you think is best?
Furosemide is usually always kind of a pretty common go-to. And in these kind of diseases, you got to probably give them pretty heavy amounts of them. Especially with nephrotic syndrome, they have like weirdly like diuretic resistant kind of problems where you have to give them sometimes upwards of 80 to 120 milligrams of furosemide to really get some of that fluid off of them. Okay. But yeah, that's kind of how I would do that. You're really kind of just managing. There's some of the other kind of complications. For example, if the neuropathy is really bad, I could do, gabapentin, or, you could even consider other types of things like, if they have coinciding depression, venlafaxine. But usually you're treating the neuropathy. You'd have to treat that. The nephrotic syndrome, diuretics, heart failure from the restrictive cardiomyopathy, diuretics. That's
sure. There's a lot going on. Absolutely.
Yeah.
Now, when when treating all of these issues, how do you monitor the response to the treatment?
So, I mean, you're treating it kind of like multiple myeloma, so I would want to get rid of the light chains. And so the best way to do that is really to monitor the light chains. You can continue to do SPEPs and UPEPs and stuff like that, and that's always like fine and dandy, but the free light chain ratio would probably be the way to go, because that's the one that's really telling me if I'm getting rid of some of those things. So I'd like to put them on this kind of like systemic chemotherapy and really see, hey, what's my free light chain ratio? Is it coming down? Are they still having a significant of an M spike in their SPEP and UPEP? Oh, they're not? All right, cool. This stuff is actually working. So that's the ultimate goal here. With respect to restrictive cardiomyopathy, it's kind of just making sure that their ejection fraction doesn't start to go downhill, and that they start to move and transition from a HFpEF to a HFrEF. And so really it would just be kind of keeping an eye on an echo. That would be my preferred kind of thing to follow up on. BNP troponin, I've never been a huge fan of like trending those things unless it's truly indicated. So I would say echoes would be probably the biggest thing to follow up with there. And then sometimes you can track cardiac MRIs, but echo would probably be the best thing to kind of continue to keep following.
And then ECGs, things like that.
ECGs aren't bad. I would, you can do that if there is something that you're potentially trying to follow along with, like an AV blockade.
Oh, right.
But I would say the best thing is really just keeping an eye on the echo and just making sure that ejection fraction and the function of the heart is remaining the same. Cardiac MRI may be helpful to see if they start to improve, and they may not have as much of that late gadolinium enhancement that's kind of popping up. And so it may kind of say, hey, this is kind of working a little bit, this therapy. But oftentimes an echo will do just fine.
And then with the low voltage ECG, is that really meaning anything?
No,
like
it's
pertinent?
It's kind of like, think about it like when you measure the electrical voltage, especially off of like your leads, it's on your chest wall. And so any kind of like, for example, bigger people, they have more tissue between that lead on their skin and between their heart. And so they're going to have lower voltages. It's the same concept, except these people, they don't have it in big tissue. They have a lot of deposits onto their heart. And so those deposits are impeding the electrical activity.
Gotcha.
That's actually being picked up by those electrodes. And so it's good to see, is it changing? But really it's the echo that's going to tell us the function of the heart. That's going to be the more critical thing.
We've wrapped up this case now. It went really well. That was super thorough. A lot of systemic involvement going on.
Yeah, for
But
real.
I think overall for the AL amyloidosis, the one that we've talked about being more common, how about just a quick takeaway and some pearls that you need everyone to make sure they know?
Yeah, so I think the big thing to remember here with AL amyloidosis is that you want to consider this in patients who have maybe that crab-like features.
Yeah.
So the hypercalcemia, the renal failure, the anemia, the bone pain, because that may cue you in to think about that. But with amyloidosis, it loves to deposit in lots of different tissues. But the most important ones are going to be the heart, so watch out for restrictive cardiomyopathy. Watch out for nephrotic syndrome. Watch for autonomic neuropathy. That's a really, really big one as well. And then another thing is watch for any kind of gastrointestinal involvement, especially the tongue. So macroglossia, and then skin findings like periorbital, like purpura or raccoon eyes. I think those are the really, really big ones. The only way that you can truly, so if it was ever asked, what is the best test that you could use to identify amyloidosis, it's always a tissue biopsy. And if they say, which one would you go to? You should always pick the least invasive, ideally, and that's going to be the key thing that they're going to test you on, my friends, is an abdominal fat pad biopsy. If that's negative, you can always follow up with the organ-specific one, as long as it's truly warranted. That biopsy, this is the key term, apple green birefringence on the Congo red staining. That tells me it's amyloidosis, but it doesn't tell me maybe the type.
Right.
And so that's where mass spec, other kind of associated tests can come in to tell them who's the daddy, right?
Who's your daddy?
Is it AL? Is it AA? Is it ATTR? Is it the beta 2 microglobulin?
Yeah, they won't forget that now.
Yeah. And I think it's always important to seek that systemic involvement. You can't go wrong with a urine protein creatinine ratio, renal function to look for nephrotic syndrome, and the echo, cardiac MRI are going to be really, really great for looking at that potential restrictive cardiomyopathy. And then after that, once you've determined the type, for this case, you treat them with chemotherapy. The VRD is the key, and see if you can get them a stem cell transplant. And if you can't, all right, keep them on the chemo. And then see, is it working? Is it working? Okay, is the heart function improving off of echo? Is there less enhancement that's actually staying around on cardiac MRI? Cool. Is the kidney function improving on urine protein creatinine ratio? Is the free light chains coming down? Is SPEP and UPEP becoming less significant on that spike? All right, this stuff's working. And so I see some improvement there.
Awesome. I love it. That wraps it up then. I appreciate that little summary there.
Yeah, man. And I really hope that you guys like this podcast on amyloidosis. I hope that you enjoyed it. It is obviously one of those conditions where it's not super common, and I think in clinical reality, you may not be experienced with it very often. However, it is something that you could see on the exam, and I think it's really important to take into consideration that. But I hope you guys enjoyed it. I love you guys. I thank you guys. And as always, until next time.